Good afternoon, Dr. Nadir.
Welcome to our Zoom meeting. Go ahead.
Good afternoon, Dr. Nadir.
Good afternoon. How are you?
Yeah. I'm
Welcome to our
good.
Zoom meeting.
Okay,
Go ahead.
I'm sharing my screen in order to present my presentation. Shall I?
Yes. Yes, please. When you're ready, go ahead. Thank you.
Okay. Okay. Can you see my screen?
Yes.
Yeah.
Okay, wait. From the beginning. Wait, how to minimize this one? Okay, wait. Okay, so
Can
this
you?
is Dr. Olivia Dutta. This is Dr. Olivia Dutta from India. And
can I stop you just at the second? You are sharing the file, the PowerPoint, not the actual presentation. So you can unshare and then share the presentation because we are seeing the slide. Thank you.
Okay, let me share one more time.
Yes.
But I share the correct screen, right? Let me share.
The best thing is to share the whole window.
Can you see my screen? Can you see my screen right now?
Yes. Hit from the beginning. Yeah.
So, yeah, from the beginning. From the beginning. So this is Dr. Olivia Dutta and my colleague, Dr. Shumaila Dutta. We both are presenting this topic. The topic is the data, how we can use the data variables and different methods of data collection when we talk about the healthcare sector and in public health. So
again, sorry, we are still on the first screen.
Okay, maybe
so,
because okay.
Right now, just unshare the screen right now.
Okay. And
then share the screen, and then there is an option of like a tab, a window. So on top, hit the window, the whole window, not a program, not a tab.
Okay, when I share the screen, so there is a share this. Okay, I'm sharing the particular screen where I'm using this thing.
Just share the whole window because we will be ending only on the slides. We don't see the presentation, the show.
Okay, wait. Okay. Is that okay? Hello? Hello?
We can't hear you, Doctor.
Yes. Can you see my screen? Can you see my screen, Dr. Nadir?
We can see the screen with the slide, not the presentation show.
Yeah, I'm sharing the slide.
No, we want you to share the show, the presentation. So it should be 2 windows or 2 slides or tabs on your screen.
I don't understand how to do this. Miss, when I'm sharing the screen, that my this thing the Microsoft this thing, PowerPoint is I'm sharing this screen.
So when you hit share screen, on the top left corner there is option for the whole screen, and below that there are options of the slide where you have the PowerPoint slide, and maybe if you open other program you will have more than one
No, I just open only one program.
So on top of the options, on the left upper corner, you will see whole screen.
Top left corner.
When you hit share, you will have entire screen.
Yeah, I have when I share the screen, it's showing our telegeriatric, then whiteboard, then iPhone. I don't know what else. There's so many things are open. So
No, I want you to hit entire screen. Do you have that option?
okay, let me share this thing to someone else. Okay, I think
All
I'm
right,
not
no
able to
problem.
understand. Just give me one second.
Okay.
Just give me 1 second. Okay, wait.
Okay.
I'm,
Sorry about that. Yeah.
I'm sending to the team leader today. All right.
It's okay. Yes,
Okay.
send it to me.
I'm so sorry.
No
Okay.
problem.
Okay, I send it to you.
No worries.
I already sent it. So let
Okay.
me stop the sharing and then you can share it. No?
Okay, I'll share it. Yeah.
No?
Okay, just give me a minute so I can download
Yeah,
it.
I sent you just now.
Hello, Dr. Malaz.
You must
Hello,
have got it.
everyone.
Yeah, did you get?
Yes,
Hello,
I
Dr.
got it.
Okay.
Hello, everyone. My name is Malaz, and I'm TAN leader. Welcome to our presentation today. Our agenda for today are going to be data and variables presented by Dr. Olivia and Dr. Shumaila. And the second topic is going to be visual disorders presented by Dr. Einas. The third topic is going to be Dr. Maisa sharing with us her personal experience. The fourth topic is going to be about Prezi AI presented by me. And the fifth topic is going to be an article which Dr. Ruwa will read for us. Okay, we're going to start the data and variables now. I'm going to share my screen.
Okay.
Can you see my screen?
Yes, it's coming.
Yes.
Okay.
Okay.
Okay. I started the presentation. Can you see it?
Yes. So today we are going to discuss about what is the importance of the data variables and different methods of data collection, especially in healthcare sector and in public health. This thing is coming. I don't know. Can you remove? I don't know how.
So, Dr. Malaz, actually, your
picture is coming.
picture is coming, and the left bottom, your picture is automatically coming with that one.
So I'm not able to see
okay. How about now?
Yeah.
It's done. It's good now. Yeah. Thank you.
Okay.
Thank you so much.
You're welcome.
So this image is representing how the raw data is collecting, then processed, and we are analyzing to generate meaningful information that ultimately help in better decision making in healthcare and public health. Let's move to the next. So here is the introduction to data in healthcare. So what are the content in this data in the healthcare? So data refers to facts and figures we use for analysis. So it is very important for clinical and public health decision making and the public health planning. For example, the blood test showing will help us to guide the diagnosis. So the bottom line is the data is the foundation of a healthcare. It helps us understand patient condition and supports the evidence-based clinical decision. So what is the importance of a data in public health? So what are the content are there? So firstly, it helps in decision surveillance, especially if we were tracking the outbreaks. It supports the policy planning and the health programs. And last, it guides the resources allocation, for example, in the staffs or medicine or funding. So let's take an example, like data helps track disease spread during the pandemic. So bottom line of importance of the data in the public health is, in public health, the data is very important for tracking disease, planning, intervention, and allocating the healthcare resources efficiently. So here is the picture where we are discussing about, we just discussed about the importance of data analytics in the healthcare. Firstly, it helps to improve the decision making. Secondly, it prevents the medication error. Third, it facilitates the personalized care and enhance the patient engagement. And at last, it improves the population health. So what is the data? So data means the raw facts and figures they collected for the references. It can be divided into qualitative or quantitative. Qualitative means it's a non-numerical, whereas in quantitatives, it is in numbers. So it becomes the meaningful after the processing and analyzing. For example, we are measuring the blood pressure, suppose, and it shows 120 and 80. By 80, it's just a data, but it becomes important when we identify it's a normal blood pressure. So bottom line of a definition of a data is the unprocessed information that gains meaning when it is organized or analyzed. So here in this picture, that is showing the data analyst, that is a science of the analyzing the raw data to make the conclusion about the information. So this picture shows how the data, healthcare data, such as for the patient records or lab results or survey is collecting, then we are organizing and analyze to understand the health trend and improve the public health decision. So data is classified into two main types. First is the qualitative, we just discussed before, and quantitative. Qualitative is when we are discussing, it's non-numerical, when we are describing it. And qualitative means, quantitative means when we are telling about the numbers or measurable. So data is classified based on its nature into descriptive and measurable forms. So first we will discuss about the qualitative data. So as we said, the qualitative data is non-numerical data. So we are just describing the qualities or characteristics. We cannot measure in numbers. For example, we are talking about the gender, symptom, blood group. So we generally use to understand the pattern on description. So here is the bar chart, the table where features, they have type or examples. Type, like if we are talking about the qualitative, that is a non-numerical, and they generally describes like a symptoms or blood group or gender. And quantitative means we are discussing about the numbers. So it's a blood pressure, what is the blood pressure, what is the age of the patient. So the bottom line is, what is the qualitative data? It is qualitative data focuses on the descriptive information rather than the numerical value. Let's move to the quantitative data. Quantitative data means when we are talking about the numbers, numerical data that can be measured or maybe counted. So it can be analyzed using statistical methods. It helps to identify trend, pattern, or relationship. For example, if we are discussing about what is the age of the patient, what is the blood pressure, or is the 120, what is the weight, and what is the height of the patient. So quantitative data provides the measurable information that helps statistical analysis. So this is the picture where we are differentiating between the quantitative data or qualitative data. So quantitative data, as we said, numericals, discrete, counting, continuous, measurement, and factual. Whereas in the quantitative data means we descriptive, we are sensing, we feel, and we hear, we see, we are describing the characteristics of the feel, sense, taste. These are the subjective. So let's move to the discrete. What is the discrete and continuous data? So so discrete data means when we are counting, countable value. For example, we said how many patients are there, how many number of the visits are there. So continuous data means measurable value. For example, what is the height, weight, blood pressure. So discrete data is counted, whereas continuous data is measured. So this is the chart where we are differentiating between the discrete data and continuous data. So what is the discrete data? The data that falls into the specific and separate the categories. Whereas in the continuous data, these will take any value but within the range. What is the nature of the discrete data? They are countable. Whereas in countable data, it's a measurable. Values that whole numbers in the discrete, whereas in continuous data, it can include only fraction and even decimals. So graph we generally see in the discrete data is a bar chart, pie chart, whereas in continuous data, only histogram or may line graph. So what is the precision in discrete data we can see? So it limited to the whole number. Whereas in the continuous data, precision depends on the precise as the measuring the tools allow. So there are the causes and the example in the discrete data is it clicks on the campaign, social media, they share or maybe likes. So number of the product purchases in discrete data. In continuous data, they have an engagement rate percentage, revenue generated from a campaign, or a customer satisfaction rate. So what are the variable? So there are the content about the variable. A variable is a characteristic that can change or maybe vary. It can take different value in a study or experiment. Variables are is important for data analysis and research. For example, what is the age, blood pressure, smoking status? So in a study, we generally say on diabetes, for example, we're taking diabetes, the age, and what is the diet, and are variable or not. So variable is the important element used to measure, compare, and analyze the data in research. So variable again divided into categorical, that is a qualitative, and numerical, that is a quantitative. Categorical again further divided into nominal and ordinal. Nominal is unordered. They are categories which are mutually exclusive. For example, we are saying male and female, smoker and non-smoker. That is the nominal. Where is the ordinal means when we are talking about the order in categories. So they are like one number means they are 1, 2, 3, 4, and minimal, moderate, severe, unbearable pain. So these are the ordinal. Now in the numerical, that is the quantitative, they are further divided into the discrete and continuous. Discrete when whole numerical values typically count. For example, number of visits and the dentist to the dentist or DMF. DMF is a decayed teeth, M for the missing teeth, F for the filled teeth. So that is the numbers we can discuss, like how many decayed, 2, maybe they are missing 1. So and how many filled, 2. So we can count it and then we can make the score. In continuous, it can take any value within a range. For example, height in centimeter, pocket depth in millimeter. That is the numerical. So and the variable is having types like they are mainly classified into 2 types: independent variable or dependent variable. So these variables were generally used to study case, causes, and the effect relationship in research. So here is the dependent and independent variable. So when we discuss about the independent variable like weight, height, ethnicity, substance exposure, medical history. So these are the independent variable. They can affect the dependent variable. For example, if we are talking about the asthma, for example, this is the, so this asthma can exacerbate if the patient having overweight, maybe height, ethnicity, for the if the patient having substance abuser, and maybe the patient already having the medical history. So so independent variable and dependent variable. So let's say the types of the treatment. For example, we are talking about dependent variable blood pressure. Suppose we are giving low dose of a new medication for level 1, and we saw there's no change in the blood pressure. But when we started giving high dose of that new medication, the blood pressure is lower. But when we talk about the placebo, there's no change in the blood pressure. So we can say the independent variable can affect the dependent variable. So what is the dependent variable? The fact that change as a result of a variation in the independent variable. So it represents the outcome, means results in an experiment. So when we are talking about the independent variable, so that goes to the experiment process, and then the dependent variable, that is the result. So the diagram shows that dependent variable is the final result of an experiment. It changed based on the independent variable, or sometimes we can say that is observe or measure, but here there is no control. So independent variable. So let's say the independent variable, the factor that causes or influences the changes. Whereas in independent variable, the results that is affected. So what is the relationship between the independent variable, dependent? Independent variable affect the dependent variable. Let's say if person is smoker, it can lead to the lung disease. If the patient having poor diet, it can lead to the diabetes. So the independent variable influences the dependent variable in a cause or maybe affect the relationship. So there are the other variable. So other variable having the confounding variable, control variable. What is the confounding variable? Factor that can influence the result unexpectedly. And that leads to the relationship, distort the relationship between variable. Whereas in the control variable, the factor remains same to ensure the accurate result. For example, we say that smoker can lead to the lung disease, but confounding is there because patient is also taking the alcohol. So that alcohol consumption affects the result. In control variable, we say we are taking the same age group. So controlling the variable helps to improve the accuracy and reliability of the research result. So here is the flow chart where we say the independent variable. That is the coffee drinking, and dependent the heart disease. But what is the confounder here? Is here the smoking, cigarette smoking. So this flow chart shows the confounding factor like smoking can influence the both exposure. For example, coffee intake and outcome, that is a heart disease. So, but here is the potential misleading is the cigarette smoking, which is not controlled because there is no control. Next. So here is the picture where we're talking about the control variable. So does the red light affect the plant growth? Here is the independent variable is the right color. This is the light color and this is the dark color. And dependent variable is the plant height. You can say here the plant size is not that grown and here is the grown. So plant height, control variable is the water, soil, temperature, or the light, or maybe night time. So the image explains the role of the control variable in the experiment. So it shows that the independent variable, for example, we are talking about the light color, is changed to observe. So it affects the dependent variable, that is the plant growth. But there are the other factors. such as the water, soil, temperature, and the time, but they remain constant to get the accurate result. So there is the example in the healthcare. So for blood pressure leads to the heart disease. There is a chance of the patient having constant high blood pressure. The patient are very prone for the heart disease risk. Poor diet can lead to the diabetes. So here is the exercise. If the patient is doing exercise regularly, the patient can control the weight and can prevent the obesity. So these examples shows how the variables help identify cause and affect the relationship in the healthcare. Variable are generally be used how the different factor influence the health outcome. So from here, Dr. Shumaila will continue the next slides.
Thank you, Olivia. So here we come with the overview of the data collection. So what are the contents? So data collection, basically it's a systemic process of gathering the information. We have to use the structure method to ensure that while we are collecting the data, it is accurate, it is reliable, and it has the validity. So main method for these data collections are the survey, interviews, observation, and records, like existing data. Proper data collection methods are essential for obtaining the reliable and meaningful result. So this is a little bit blurry. I can explain. So when we are doing, first of all, we are getting the data. We are doing the data analysis and we are doing the data wrangling. By that, we are gathering the data. We start with the co-creating the clinical questions. We assess the data faculty. That will lead to the data gathering, and we will do the data analysis and data wrangling. We will come to the conclusion that is the clinically actionable information is present. Then this clinically actionable information will again lead us back to the assessing the data as the faculty. And then finally, it will lead to the knowledge translation and the implementation. So now we have two type of data. They are the primary and secondary data. So what is the primary data and what is the secondary data? By definition, the primary data is collected firsthand, while the secondary data that is already present. Sources from the primary data, we already discussed, that is a survey, interviews, and experiment. And for the secondary data, reports, records, and the databases. What are the advantages of the primary data? We will be getting the more accurate and the specific results, but in the secondary data, it will save the time and cost. So primary data is the main one, which is original and specific, while the secondary data that is readily available and it is cost effective. So survey and questionnaires. So contents used to collect the data from the large population. Why we do the survey and questionnaire? So because we wanted to collect data from the large population, we wanted to have a quick and the cost effective method. And the third thing is consist of the structured set of questions where we use these surveys and questionnaires. So we use them in the health surveys and the disease prevalence study. Survey, they are basically widely used in the public health to collect the large scale data efficiently. What designing questionnaires? So what are those? They will provide us the clear, we have to use the clear and the simple language for them. We have to avoid the leading or biased question. We have to make the questions relevant and specific. We have to be used the logical and the organized structured. Well-designed questionnaire improve the accuracy and reduces the bias in the responses. What will the interviews do in data collection? This is the direct method of data collection through the interaction with the participants. It has two types: structured, in which there is a fixed set of questions are available. Unstructured, we are flexible, we having an open discussion, and it will provide the detailed and in-depth information. Interviews somehow allow deeper understanding by collecting the detailed response from the participants. Observational data. So now what are the content for the observational data? Data is collected to the direct monitoring of the subject. We will not be having any interaction with the participants, and that is not needed also. So used to study the behavior and the real life practices. Example, observing the hygiene practices in the hospital, monitoring the patient's behavior. Observation help collect the real world data without influencing the participants. Secondary data sources. So the direct method of direct data collection through the interaction with the participants, we will be having again two types. Structured, there will be the fixed set of question, and the unstructured, there will be the flexible open discussion. It will provide us the detailed and in-depth information. Interviewer will be having the questions. The participants will be replying them, and there will be the detailed response. Interviews allow the deeper understanding by collecting the detailed response from the participants. Secondary, what are the sources for the secondary data? The first source is the county health departments. Second one is the vital statistics like birth and death certificates. Third is the hospital, clinic, school nurses records. Fourth one is the private and foundation databases. Fifth one is the city and the county governments. Sixth one is the surveillance data from the state government programs. And the last one is the federal agency statistics like CNIS and the NIH, etc. Now, medical records and database. They are we will categorize them into three. It will include the electronic health record. It will include the disease registries and the health database. It will provide us the large scale and the structured medical data, where we use these medical records and databases. We use them in the epidemiological study. We use them in disease tracking and analysis. We use them in the healthcare planning. Medical database provide us most reliable and the large data sets for the healthcare research and disease decision making. Sorry about that. So we having this is the picture. So patient has an appointment. We will generate the billing, and that bill is received by the patient. Doctor and patient both will attend, create the medical record. Doctor will create the medical record, it will share with the patients. And that medical record also contain the prescriptions. Here come the beautiful picture. How medical data is created. So we have a patient and medical and treatment information, lab data. We collect the data like this. Like first, we will getting it from the medical treatment information, DPC, then health claim data, then the electronic medical record and the lab data. Everything is available in our computers because everything is digitalized now. Then we will be digitalizing it. We will be summarizing it. It is coming from the hospital, clinic, everywhere. And then we will extract that data and anonymized this one. Then after hospital A, hospital B, and then hospital B again, aggregate, analyze, and process. And we will be utilizing this data. Data accuracy and reliability. So what is the accuracy? Data must be correct and free from the errors. Reliability, we measure repeatedly this data, so the reading should be consistent. This is called the reliability, that we have to rely on that. Valid and reliable data leads to the correct conclusion and decisions. High quality data is essential for the accurate clinical and research decisions. Accuracy, bullseye. Correct decision, on point. Reliability, consistent. Multiple times we do the calculations, it should be consistent reading. Biases and error. So when we have the data, we will be having the errors too, biases too. So now basically we will be having the two major. One is the selection bias. Occur when the sample is not representative of the population, like we choosing from the hospital a certain population in the hospital, can lead to the incorrect conclusion. Measurement bias, error that occur during the data collection or recording, it can affect the accuracy of the result. So measurement. How it impact biases and error can reduce the validity of research finding. Minimizing the bias and error is essential for accurate and reliable data collection. Like how the error come. Somehow, some are the selection bias, measurement bias. Other than that, we can have the misspelled name. We can have the wrong addresses of the patient. And we have the countless duplicated patient too. Selection bias. So type of the bias or error when the researcher chooses who is included in a study. A result cannot be applied to the population. It is only applied to the certain patients. No external validity, inaccurate representation of the relationship. Error. So there is the random error and the systemic error. Two types of error can occur. When there is a systemic error, it further classified into selection bias and measurement bias. Measurement bias can further classified as a random misclassifications or non-random misclassification. And the non-random misclassification further classified into three, that is the recall bias, observer bias, and the instrumental bias. What is the measurement bias in AI? So we have a patient or person who is, we have collected the data, height is 5'11". But when we are doing the training data, we will be getting the height is 5'9". We will be using this artificial intelligence model. And by that way, we will figure out that this patient shirt size is medium. So by that way, we can figure out the height. So measurement bias occur when the data collection methods are flawed, leading to the inaccurate results. In this case, a faculty ruler underestimates the kid's height, causing the model to recommend the undersized clothing, as the data used for training is incorrect. Now, when we have a data, when we have a healthcare system, when we have to go for the public health, we will be having some ethical consideration too. We have to take the patient consent. Participants must be agreed before collecting the data, and the participation should be voluntary. And there should be confidentiality. Here in USA, it's a HIPAA violence when you breach the privacy confidentiality. So personal information must be kept private. Data should not be shared without permission. Other key principles, we have to respect the participants. We have to protect their privacy. Ethical practices ensure the trust, safety, and respect in the healthcare research. Lastly, so there are the four principles of the healthcare ethics. One is the autonomy. Whatever the patient say, we will do that. We will go with the patient saying. The other one is beneficence. We have to do whatever good for the patient, beneficial for the patient. Non-maleficence, no harm to the patient. And the justice, it is the triage. Thank you, everyone. So basically, conclusion. Data is the foundation of the modern healthcare and public health. Proper data collection method ensure the accuracy, reliability, and validity. Understanding the variable help in analyzing the health pattern and relationship. We have a data. We'll do the analysis. We'll make a decision. And from there, we will come to a better health outcome. So in the end, conclusion, accurate data and proper analysis lead to the better clinical decision, improve healthcare outcome, and the effective public health planning. Conclusion, that we have a data variables and different method of data collection, especially in the context of the healthcare and public health. We have a data, we will analyze that, we will make a decision, we will implement in the healthcare system, and we will get the better health outcomes. Thank you so much, everyone. Thank you for your time. Thank you.
Thank you so much.
Thank you both.
Thank you, Dr. Nadir.
And thank you both, Dr. Shumaila and Dr. Olivia. This is great. And I just want to highlight, for example, patient with blood sugar or diabetes. So we check their blood sugars, and you can check it once a day. You can check it more than that, let's say 4 times, and you can get the average. So it will help us understand what's going on with the patient. And if we want to do the lab, for example, A1C, we can check that and see. It will help us make conclusion about the last few months. How is the blood sugar for that patient? And there are some cutoff. And this will help us address how do we be aggressive to treat the patient, especially if they are young, so that they can prevent long-term bad effects of high diabetes or high blood sugars. And they can lose their eyes, kidneys, and amputation, and so on. So if you want to be aggressive, there is some guidelines. These guidelines comes from this data, and if you don't collect the data correctly and save them correctly, then you cannot analyze and end up with the health measurement or the guidelines as mentioned in this presentation. And this is wonderful for you guys. So thank you so much. And if there is any questions, please go ahead. If not, we can move on to the next topic. Thank you, both of you. Great presentation.
Dr. Nadir, I want to know. Okay.
Go ahead, Rupa.
I want to know the references for the presentation so that it will help us in future. May I get the reference, please?
So if Malaz or Olivia, if you can upload the file to the app. So I'm going to show you here, just a second.
Okay, I will do it.
So for Rupa, if you go to the app and scroll down to today's meeting, so upcoming meeting, it's going to be today's meeting. And at the end here, at the lower part, you will have a file number 4, file number 2, each one corresponding to one of these topics. So you'll have the reference there.
All right, Dr. Nadir. Thank you so much. Yeah, thank you.
Welcome. Thank you both.
Much.
Thank you all of you.
Our next presenter is going to be Dr. Einas.
Hello, Dr. Nadir, and hello, everyone. And thank you, Dr. Shumaila and Dr. Olivia, for your presentation. I'm Einas Tahir from TAN 1 team, and today we're going to explore the critical topic of visual loss and various other eye conditions common in our aging patient.
Can you see my screen?
Yes, I can see it. So by the end of this session, you should be able to describe the leading causes and the pathophysiology behind visual loss. We will also cover techniques for prevention and treatment, how to identify common eye disorders in older adults, and strategies for low vision rehabilitation. We have a lot to get through today, but we're going to start with common conditions like refractive error, cataract, age-related macular degeneration, diabetic retinopathy, glaucoma, ischemic optic neuropathy. And later on, we're also going to finish with practical low vision rehabilitation strategies. Starting with the impact of visual loss, why do you think this is important? It is vital to understand that the scale of the importance of this issue because visual impairment, it is defined as having an acuity less than 20/40. It affects around 20 to 30% of people aged 75% and 75 years of age and older. And when we look at the legal blindness, which is acuity less than 20/200, it affects around 2% of that same age group, which is 75 years and older. And half of the entire blind population is 65 or older. So it's really important to screen in order to prevent visual loss, and early detection is actually the key. The American Academy of Ophthalmology recommends that patients 65 and older, they should receive comprehensive eye exam every 1 to 2 years. The most important thing in a primary care setting, and the most important question that we should ask our patient is, has your vision changed? We're going to receive common complaints that includes red eyes, ocular swelling, double vision, sudden vision loss, or floaters. We should always check visual acuity and look for afferent pupillary defect, as decreased vision can signal a serious underlying condition. So these are common symptoms and signs of eye conditions that require immediate referral to an ophthalmologist. We have over here, most of these, the common symptom between them is decreased vision. So when we're speaking about retinal detachment, we're going to receive symptoms like flashes, floaters. Patients are also going to complain about curtains over their vision. We have also acute angle closure glaucoma. Patients also complain from decreased vision, but also there is eye pain or headache. We have also fixed dilated pupils, hazy cornea, nausea and vomiting. And when we're speaking about the ischemic optic neuropathy, we have symptoms like swollen, like sudden loss of vision. It could be complete or partial in one eye. But when we're speaking about central or branch artery occlusion, we have the sudden painless loss of vision in one eye, but at the same time, we could have symptoms of giant cell arteritis, including the jaw claudication, headache, transient diplopia. And this requires the use of the stroke protocol within 2 weeks of the event. We have also the retinal vein occlusion. It often presents as sudden painless vision loss with a visible hemorrhage on fundoscopy. Other conditions that needs our attention include scleritis, corneal ulcers, and other forms of uveitis, anterior and posterior uveitis. So over here in scleritis, it's often associated with autoimmune diseases. Anterior uveitis and posterior uveitis will also have the complaint of decreased vision, but we'll have also floaters in the posterior uveitis, but when we're speaking about anterior uveitis, we'll have photophobia and eye redness. In corneal ulcerations, we have corneal infiltrations, and in uveitis, we're going to have photophobia and eye redness as well. Another thing that we should look at is herpes zoster ophthalmicus. Patients are going to complain of decreased vision, but also they're going to complain from skin lesions, which is the Hutchinson sign, where patients are going to come with or present with a lesion over their face that surrounds their eye and the tip of their nose. Okay, so it's, this is the Hutchinson sign, and it's really important indicator of the eye involvement. Next, please. We have also the subconjunctival hemorrhage, dry eye, blepharitis, lid malposition or lid exposure, and allergic conjunctivitis. So these conditions are commonly seen by primary care providers, and they could be treated by primary care providers. They do not need ophthalmology or they do not need referral to an ophthalmologist. We have the subconjunctival hemorrhage. It is treatment is actually supportive with artificial tears. Dry eyes, treatment is by artificial tears as well, and cyclosporin 0.2% eye drop. We have the blepharitis. Treatment is through lid scrubs, and lid malposition, we're going to use ocular lubricant, and allergic conjunctivitis through cold compressants, allergen avoidance, and topical and systemic antihistamines. For viral conjunctivitis, supportive care with artificial tears is actually usually enough. though you should refer them if their vision is significantly affected. But for chalazion, we should start first with a warm compresses first. And if you suspect herpes simplex keratitis, we're going to start with the trifluoridine drops, and then we're going to refer them. But as for acute closure angle glaucoma, we can start with acetazolamide while you arrange for immediate referral to an ophthalmologist. So if a patient complains of a new flash or floaters or a sudden decrease in vision, we should refer them immediately to an ophthalmologist, as these could be vision-threatening problems. And if you have double vision diplopia, we should distinguish between a monocular that happens in cataract or refractive error and binocular, which could indicate a microvascular infarct. Now we have the keratitis secum, which is dry eyes. This is quite common because tear production is going to decrease naturally with age, and patients will describe symptoms like foreign body sensation or redness. We should manage this with artificial tears during the day and ointment at bedtime. And in severe cases, 0.2% topical cyclosporin can help treat the underlying inflammation. So as we age, the eyelids are going to lose their elasticity, and you might see blepharochalasis, which is the drooping of the brow, and the blepharoptosis, which is drooping of the eyelid. Both of them can impair vision if it's quite severe enough. And we also see ectropion and entropion, which is when the lids turn inward or outward. And this also causes significant discomfort, and they should be corrected through surgery. As for herpes zoster ophthalmicus, this is painful reactivation of the varicella zoster virus that affects the trigeminal nerve. Again, if you see the Hutchinson sign on the nose, we should watch out for it and refer immediately to an ophthalmologist, as it means that the eye has been involved. Early treatment is going to be with oral acyclovir or famciclovir, which can shorten the course of the disease. And also we have another thing, we have the post-herpetic neuralgia. The post-herpetic neuralgia, this can be quite debilitating. So we can treat it with using local ointments or systemic medications like gabapentin, TCAs, pregabalin, and the narcotics. So when we speak about refractive errors, along with cataracts, these are actually leading cause of visual impairment when we're speaking about it globally, worldwide. So we're talking about myopia, which is the nearsightedness, hyperopia, farsightedness, and astigmatism, which is visual distortion. So there's also the presbyopia, which is the decreased ability to focus on near objects, and usually it starts after the age of 40 because the lens is going to gradually harden, and these are corrected with glasses, contacts, or laser surgery. Next, so here we have the symptoms for cataracts include increased glare, decreased contrast sensitivity, and changes in how a patient perceives color. The important risk factor for cataract, we have age, decreased vitamin intake, light, which is ultraviolet light exposure, smoking, alcohol use, long-term corticosteroid use, and diabetes mellitus. So these are the percentage of population with cataract. So when we're speaking about patients who are 75 years and older, around 50% of them have cataract. But when we're speaking about patients 65 years and older, around 20% of them have cataract. Treatment of cataract is very successful. So a surgical extraction, it is performed around 3 million times a year in the United States, and about 90% of patients are going to achieve vision of 20 over 40 or better after the surgery. And the procedure usually involves local anesthesia and placing an artificial lens. Now, speaking about the age-related macular degeneration, this is the most common cause of irreversible blindness among older adults in the developed world. We're going to categorize it as we have the non-exudative and the exudative. The non-exudative, which is the dry, characterized by the drusen, and then we have the exudative, which contains new blood vessel growth. So for the dry form, we have a treatment could be vitamins like vitamin C, E, zinc, or lutein. This can decrease the risk of progression. But when we're speaking about the wet form, we need to use the intravitreal anti-VEGF vascular endothelial growth factor injections. So this is to show you the effectiveness of treatment. They're going to, when you see these images, you can see the resolution of a submacular hemorrhage after the anti-vascular endothelial growth hormone, a growth factor therapy in patients with a neurovascular form of the ARMD, age-related macular degeneration. So this is before treatment and this is after treatment. You can see the resolution of the submacular hemorrhage. Speaking about diabetic retinopathy, diabetes is actually a major threat to vision. And of those who have type 2 diabetes for at least 10 years, 70% are going to show signs of retinopathy. And the most important factors are disease duration, how long the patient has been diagnosed with diabetes, and blood pressure and sugar control, whether or not they're controlling their blood pressure or sugar. And treatment options, and they include laser therapy and the intravitreal injections. Diabetic retinopathy, the stages include the non-proliferative, the pre-proliferative, and then the proliferative. The non-proliferative stage, this is the early stage. Okay, so we're going to see the microaneurysm, hemorrhoids within the retina, and exudates, and we're also going to see macular edema. The pre-proliferative phase, this as it advances to the this comes after the non-proliferative stage. So we're going to see extensive hemorrhoids and intraretinal microvascular abnormalities, which means that the capillaries are shunting blood because of non-perfusion or ischemia. Okay, here we're going to see severe non-proliferative retinopathy with macular edema. This is before taking the anti-vascular endothelial growth factor therapy, and this is after taking it. Okay, lastly, we have the proliferative stage. This is characterized by neovascularization. We're going to have new blood vessel growth of the retina or the disc. And these vessels, these are very fragile and can cause vision loss through vitreous hemorrhage or traction retinal detachment. The slide also shows the resolution of severe neovascularization of the disc after taking the vascular endothelial growth factor therapy. Now we're going to speak about glaucoma. Glaucoma involves a characteristic optic nerve damage and visual field loss. It's the second leading cause of irreversible blindness worldwide, And while elevated intraocular pressure is a major risk factor, many patients actually have normal pressures. Primary open-angle glaucoma, this is the most common form because drainage happens slowly, pressure builds up gradually, and patients are typically asymptomatic and may not even realize that they have significant visual loss until they see an ophthalmologist. In acute angle closure glaucoma, unlike the open angle form, this involves a increase in pressure and it presents with redness, pain, and acute vision loss, often accompanied by headache and nausea. This is actually an emergency, a medical emergency that requires immediate referral to an ophthalmologist. Glaucoma management. So managing glaucoma centers on lowering pressure. This is the most important thing. We're going to use medications like the aqueous suppressants or aqueous outflow facilitators. We can also use, if this was not enough, we could move to the laser trabeculoplasty, drainage devices, or filtering services. Okay, we have also the anterior ischemic optic neuropathy. This condition results from microvascular occlusion of the blood supply to the optic nerve. And it's typically due to either we have atherosclerotic disease or inflammation, such as temporal arteritis. And the result is actually acute, sudden vision or field loss. On examination, you're going to see a pallid swelling of the optic nerve head, as shown in this image of an older adult patient with anterior ischemic optic neuropathy. Now, I want to speak briefly about the Charles-Bonnet syndrome. Charles-Bonnet syndrome, in this syndrome, it involves a visual hallucination in patients who have significant visual impairment. And these can be simple shapes or complex images like people or animals. And it's really important to reassure these patients because they have clear understanding and awareness that these visions are not real. Now, low vision rehabilitation, it's available to patients with visual acuity that is less than 20/60. We're going to focus on improving light and using bold, large font materials. We also use magnification tools and smartphone apps that can recognize money or provide dictation. And for patients with acute age-related macular degeneration patients with the central visual loss, we can train them in eccentric viewing. So essentially learning to use off-center fixation. Now, to close out our main discussion, we need to look at choosing wisely recommendation. So we should avoid preoperative medical tests for eye surgery without specific indications. Since most acute conjunctivitis is viral, we don't treat it with antibiotics. And finally, don't jump to punctual plugs for mild dry eye syndrome before trying other medical treatments first. So in summary, vision loss is quite common among older adults and can lead to a loss of independence and lowers the quality of life. And as primary care providers, we should routinely screen our patients and remember that treatment options are available for many of these conditions. Now we have some cases, and I need your interaction. So And I also need a volunteer. So I'm going to read, and I need a volunteer who would going to answer this. So here it says, an 84-year-old man is brought to the office because his right eye is red. He seems to have cold and is sneezing. There is moderate watery discharge. He says that the eye feels gritty but does not itch. He has no eye pain or sensitivity to light. There is no baseline information on visual acuity, but he thinks his vision is unchanged. Nursing home staff confirmed that there is no evidence of a change in vision. In history, he has Alzheimer's disease. On examination, there is eye movements. The eye movements are intact, and there is moderate bulbar conjunctival injection of the right eye, and conjunctival hemorrhage extends from 6 o'clock to 9 o'clock positions. The right preocular lymph node is slightly tender. So what is the most important management? Should we use antibiotics, or should we refer him to an ophthalmologist, or give him artificial tears, or should we try antihistamine drops?
I will try, okay, but don't try to judge. So this is
Go ahead.
great. Most likely he's have dry eye, but right periocular lymphadenopathy. It's most commonly with and tender with we. There is infections, maybe viral or bacterial. Subconjunctival hemorrhage is very common in old age because the blood, or maybe there is a treatment, but there is no need to treat it. Subconjunctival hemorrhage is sometimes idiopathic and self-limited hemorrhage. So maybe he need to artificial tears at this time. But if there is no discharge or painful eye, so you exclude glaucoma, you exclude the adenovirus, there is no discharge, no itchy, you exclude the conjunctiva, allergic conjunctivitis. So I don't know.
Yes, very good. Thank you for your input. It's very interesting. And you're right. The symptoms over here are towards viral etiology. And we should be using artificial tears as needed. So we do not, as you mentioned, we do not need to treat the conjunctival hemorrhage because it's quite common. So you're right.
All right.
Okay, thank you. Next. Yes, this is the question. Next slide. So we have over here a 90-year-old woman is considering whether to have cataract surgery. She's able to read large print books on her ebook reader and solve crossword puzzles, two of her favorite activities. She has bilateral wet age-related macular degeneration and receives anti-vascular endothelial growth factor. The left nuclear sclerotic cataract has worsened, and vision in her left eye has decreased from 20/40 to 20/80. Vision remains 20/60 in her right eye. She's frail. She moved to a nursing home from assisted living 1 year ago when she began to need assistance with bathing, dressing, and toileting. History, she has age-related macular degeneration, aortic stenosis, and percutaneous aortic valve replacement has been done 2 years ago, asthma, and osteoarthritis. So here it says, what is the most likely outcome if she has the surgery? Next slide. Which one of the following is the most likely outcome from cataract surgery? Is it going to be more rapid progression of the age-related macular degeneration in the left eye, or correction of vision loss in the left eye, or improved ability to read and solve crossword puzzles, or better monitoring of AMD?
I will try again, okay? So because she had AMD, age macular degeneration in the left eye, so because there is a cataract that make difficult to follow up how it's progressed AMD, so it's better monitoring of AMD.
Yes, very good. Very good. Because even though that surgery can remove the cataract, the problem is actually with the underlying AMD. It means that we cannot fully correct the AMD, but it's really important to monitor her macular disease. So yes, better monitoring of AMD. Finally, we have here a 75-year-old man is seen for a routine follow-up related to diabetes mellitus, which is not under optimal control. It is apparent that his right eyelid is drooping. He says that he has been aware of the droop for the past few months, but is not bothered by it. He has no double vision or blurring of vision. He has not noticed any difference related to sweating on the right side of his face. There's no new muscle weakness or pain. And on examination, the right upper eyelid covers the cornea almost to the pupil. The pupils are equally round and reactive to light and accommodation, and extraocular movements are intact. The eyes are aligned and his face is symmetric, except for the lead creases. Next slide. Which one of the following is the most likely cause of his blepharoptosis? Is it prolapse of the orbital fat pad, Horner syndrome, third nerve palsy, or levator dehiscence?
So it's related to the eyelid, right? Okay, I will give a chance to anyone if want to try.
Okay, I would just try, but I will go with
Okay.
the third nerve palsy because of the diabetes he had. I don't know, I'm not sure.
No problem. Does anyone else have another answer?
I would
Yeah.
say levator dehiscence.
Levator dehiscence.
Yes.
Yes. Levator
Because,
dehiscence, but why?
Intact, the pupil is normal, extraocular movement is normal. There is no disturbance in the facial, like sweating. So
Yes, exactly.
it's a superior.
Exactly. Yes, very good.
Superior
So
vision of the motor nerve. So,
yes, the levator dehiscence is the answer because, as you said, we have lack of pupillary involvement and extraocular movement is also normal. So it's not going to be Horner syndrome. It's not going to be a nerve palsies. Okay. So thank you all for your time and yeah, thank you for the participations. I really enjoyed presenting this, and I hope it was beneficial and useful for you all. And thank you,
Thank you
Malaz,
so much.
also for helping me with this,
Thank you, Einas.
moderating it. Thank you so much.
Thank you.
Thank you, Dr. Einas. If there
And
are
thank you,
no
Dr.
more
Nader, for the
questions,
opportunity.
you're welcome. Thank you so much. So we can move on to the next topic. Our next Dr. Maisa.
Our next is going to be Dr. Maisa.
Maisa.
Hello, Assalamu alaikum.
Alaikum
Nice
salam.
to meet you all. And it's my pleasure to share my experience today towards the residency. Initially, I will just start with simple brief introduction about myself. Then I will tell about my journey till reaching the point of match. And then I will give like just very few tips that I think made it easy for me to get this position. Regarding myself, my name is Maisa Osman. Currently, I'm an assistant professor at University of Khartoum, Department of Pathology. I graduated from University of Khartoum in 2012. And then I did a clinical degree in pathology in Sudan. After that, also, I did master's degree in medical education. And then after the war, I relocated here to US, and it was in 2024. So my journey towards the residency started since March 2024, and hopefully completed in this March 2026. So it took me like 2 years to complete it. I started preparation for step 1 in March 2024, and I sat for the exam on August 2024. Then I sat for step 2 on February 2025, and then the OET on May 2025, then step 3 November 25. So, and down the way between doing the OET and starting preparation for step 3 exam, I do 2 observerships, which really improve my chances to get position in the residency. And during these 2 observerships, I started the preparation for step 3, because I'm a kind of person who believe that like small frequent works all the time help us to reach our goal without being overwhelmed. And actually, this was my policy throughout my career. That is why I used to start to prepare for everything early on. And I think this is a very important key factor to lead to success. And as I said, you will be like very relaxed, not being overwhelmed. So this is my journey. And I think the tips that help me a lot to get this position is that number 1 is believing in Allah subhanahu wa ta'ala, and then believing in myself. All the time we hear like very disappointing sentences, and sometimes our colleague disappoint us with their journey, but all through the time you have to believe in yourself. This is number 1. The second thing is dedication, full dedication. This is a cornerstone for reaching our goals. And as I said, small frequent works. So to be practical, my recommendation for you, after like completing all steps exam, I know that just step 1 and step 2 and the OET are the mandatory requirement, and step 3 is just like booster for taking the position. Is not mandatory, but it is preferable to take it before the match. And for me, for those who did not sat for step 2 specifically, please take considerable amount of time and effort to get high score in step 2. It does matter a lot in match nowadays. And then if you already did and completed your steps, when the ERAS token like start, which is the platform in which we do our application for the residency, it usually starts on June. So once it opens, please take it and start building your CV on it, because completing the form and application, it will take a lot of time. That is why I recommend to dedicate like at least daily 1 hour in ERAS. You need to know and understand the platform itself. You need to organize yourself, sometimes add something and sometimes delete things and so on. And also I recommend that while we are filling the ERAS, to try to reflect a lot of experiences. I mean diversity of experiences in form of teaching experiences, leadership experiences, research experiences, and clinical experiences. And at the same time, try to reflect that you are in a continuous growth and improvement. And also being very honest about yourself when filling the ERAS is very important. Then my second recommendation is that after you submit your application, which usually at the end of September, immediately you should start preparation for interviews, because also interviews like take a great way in evaluation and in taking the spot for residency, because so many people like got interviews and they didn't find the chance to have match. So interview preparation is also very important things we have to consider it. There is like a specific date for which the interview, which is called interview release date, which is 15th of October. But my recommendation, whenever you submit your application, you have to start interview preparation. And again, like, for example, dedicate, even if like half an hour or only just 1 hour daily, chatting with even friends. Even we don't need to take like professional preparation with a professional coaches. That cost a lot of money. For me, I was a person who was very bad in English, and like I have a problem in communication, especially when I came to US. I dedicated my time just for reading for the steps. That is why I needed to chat with friends to allow my like English language to be in a good position. So try to do it, and this like I'm sure it will help a lot. At the beginning of our preparation, we used to struggle a lot to find words, to find sentences, to express ourselves. But at the end of like interview season, we found it very easy and even enjoying time chatting with friends for preparation for interview. And also one of the things that I think helped a lot, as I said, the observership. This is very crucial time and important time. We don't do observership just to fill our paperwork that we did it, but to gain the exposure for the health system here in the US, number one. Number two, to build relations. This is very important when you build relations, even with the residents, by the way, because it also weighs a lot in choosing you in a program. They took their vote very importantly. And also, we can take recommendation letters if we are doing some observerships. So all these will help to boost our position. And finally, I want to conclude that please don't underestimate yourself and don't underestimate your experiences. Those who did anything in Sudan. For me, I did nothing in US apart from these two observerships. And even I have no research experiences, but I have like, I have no research publications, but I have a research experiences. I impart in many researches. So we can write it in the eras, even if we did not publish anything. So I hope like this very brief talk about my journey and about the very general tips about getting position in a residency help you. And if you have any questions or if you need any help, especially in pathology, I'll be more than happy to do that. Thank you very much for this opportunity, and thank you for your listening. Thank you.
Thank you so much, and Dr. Maisa, for sharing all this great experience and tips. If there are any questions to Dr. Maisa, please go ahead. I have one question. How did you prepare for step 3? What resources did you use?
Okay, well, for me, my main preparation platform or material was the U-Word, actually. I can say it was my only resource. The key factor is the way that we handle the U-Word. The U-Word is very good resource, but how we deal with it. We need to take notes, and we need to wrap these notes up, and we need to come and go through these notes a lot. And also we need to do a lot of assessments to judge ourselves. and to know where we are exactly sitting, what are our weaknesses, and then to build on them. And also we have the CCS cases. You know that we have a special part of the exam, which is the CCS cases. There is another website for CCS cases, also helped a lot. So these are the main two resources that I depend on. And if I can share even my score, it was not that so high, but I think it's reasonable, which is 232.
Yeah, I ask about that because to the fellows in this program, most of the residency program, they are required to have you pass step 3 before finishing the first year, going to the second year. Because if you don't pass, even if you finish the first year, you are not allowed to go to the second year. So they gonna lose you. You're gonna lose the spot there, and you have to take the step 3 and pass it, and then join the program again. They may have someone else fill that position in the meantime, because for them it's important to have people working, filling these gaps or these positions. So it's important. So if you take it before the interview, like Dr. Maisa did, you will take that headache off their head. So they know you already accepted, you've been accepted to first year, and you're going to continue in their program for the whatever years, 3 years or how many years, depending on the specialty. But it's an important thing for you to have, and you will be a good candidate compared to others. Thank you.
Sure.
We have some questions on the chat, if that's okay with you.
Yes.
Yeah.
Go ahead.
Yeah. The first question is by Maison. She's asking, is internal medicine recommendation okay for pathology?
Okay, this is very good question. Most of the pathology programs say it is preferable to be at least one of the recommendation letter from a pathologist. But if you had recommendation letters from internal medicine department, it does work, especially if it is very personalized. This count a lot. But try also to get at least one from a pathologist. Just to show that you are interested in pathology. Pathology residency needs to know that you are sure and the career that the career of pathology is your preferable career, because so many people in the past used to use the pathology as a bridge. They get pathology residency, and then after completion of the first year, they shift to another career. That is why the pathology residency needs to know that you are dedicated for pathology. Yeah.
Okay. The next question is by Ala. She's asking how to secure a pathology observership.
Okay, well, you can go through the websites. Some of the programs list them in their website that we offer observerships. Try to start sending emails or contacting the programs as early as possible. Like, for example, since February, before starting of the match season. And the second thing is connections, for sure. Connection. If you know anyone, even if he or she is not in the department of pathology, like it's just resident in another department or attending in another department, also can connect you to the people of pathology, and you can secure a position for observership. Mine, I got these two observerships from connections, to be honest.
Okay. The next question, they're asking if you used any other resource for Biostat other than UWorld.
For step 3, you mean?
I think they mean step 2. No, she means 3.
Step 3. Okay, well,
Yeah.
you know that statistics start from step 1. We have statistics. Step 2 also we have some statistic, and step 3. So I depend only on the resources in the U word. Also, there is a specific section in the new U word version that you can activate statistic questions separately. In addition to my past resource, which was Randy Nail videos.
Yeah, I heard those are good. Ala Al-Bashir is asking if they can contact you through. We can't hear you,
Yeah,
Dr. Maisa.
You are mute, Dr. Maisa. You are mute.
Okay, well, so I'm sorry. I can hear you and I can answer your question. Go ahead.
They're asking if they can contact you. Dr. Ala Al-Bashir is asking if they contact you. If they can contact
Oh,
you.
yeah, sure. Yeah, sure. I will just type my phone number in the chat and everyone can. I have a WhatsApp in this chat.
Thank you very much, Dr. Maisa. This is very...
Yeah, sure. Anything else?
No. Thank you very much, Dr. Maisa.
Thank you
so
very
much.
much. Yeah, sure.
Congratulations again. Thank you so much, and we wish you all the best.
Thank you very much, Dr. Nadia. Bye-bye.
Have a good one. So anyone else? I'm not sure if anyone in the group here matched.
Our group?
If not, then
No.
we can move on to the next topic. I invited some people to share their experience, so I'm not sure. So
Yeah,
go
they
ahead
can
for
they
the
can
next,
share it.
I don't think someone is here, so.
Okay. Someone is asking, what do you mean by personalized letter of recommendation, Dalia?
So it depends on, yeah, go ahead.
No, Dr. Nadir, go ahead. For sure, you know more about me than this.
No, I just want to highlight that when you are doing, let's say, observership or in this program, for example, you are participating with activities, mention them to the writer. So for me, for example, if you want to ask me to write you a letter, we have a way for you to list all the activities that you did with us. Let's say you participate in presenting a topic like Dr. Shumaila did today. So she will put that she presented a topic or how many presentations during the fellowship she did. That can be teaching skills for her. Also, if one is working in mobile application development, for example, or publishing a poster in one of the conferences. So all this will be as specific. When I write the letter, I will say this candidate did participate with teams, work with teams, and dedicated and whatever. And these examples will show why I'm saying that. A team leader or a project leader, something like that. They completed that and presented it in a big conference or something. For you, if you are doing a rotation or observership with some of the doctors, when rounding, try to ask questions, get involved, try to explain things to other, if they have medical students, for example. This will show the writer during your rotation that you are actively participating, you are engaged, you are not like just following and observing only passively. Sometimes these writers, let's say you're going to spend a month, within 2 weeks, you can ask them, what else can I do? So that when you write me a letter, you can write something good, something like that. So some of them may say, I want you to present a case. I want you to do this. So when they write the letter, they will say, this person participated in our roundings and this and this, and they have a good case that they presented and so on. So it's kind of personalized to you, your personality, your active engagement, how active you are, and so on. But go ahead if you want to add, Dr. Maisa.
No, nothing to add. Thank you, Dr. Nadir. Thank you.
We have one last question, and then we can continue with the presentation. Ziad is asking, what is a safe score in step 2 to compete in general surgery?
Okay, well, this question, I think it's difficult for me because I took the pathway of pathology, but generally people nowadays saying score of 250 and above, it would be considered good score, at least for pathology, internal medicine. I mean the specialties that are not much competitive, but for surgery, for sure, it's very competitive. You have to ask further about this. I'm sorry.
Thank you, Dr. Maisa. Thank you very much.
Yeah, welcome.
Okay, I'm going to be the next presenter. And I'm going to show you guys how to use Prezi AI today. I'm just gonna share my screen. Can you see my screen?
Yes.
Okay. Okay, so Prezi AI is a new tool. It will help you guys create presentations without using the traditional way in making the presentations. Basically, you're just use the AI help to create it, and then you can adjust it later on. You can start with giving it a prompt, and it will create it for you. You either can start from scratch, or you can upload a PDF file or a previous PowerPoint file, or you can just give it the prompt and it will create it for you. This is the one from scratch, but it's just like a traditional one. So we're gonna start the idea one. Can someone give me an idea for the AI to make a presentation? Any topic. Okay, let's start.
Fibromyalgia.
Sorry?
About fibromyalgia. Fibromyalgia, sorry.
Fibromyalgia, okay. I'm gonna make it right about fibromyalgia. And I'm gonna ask it to make it only 10 slides, for example. I don't know it. I'm gonna ask it to create it. It's gonna create it from scratch with all the visuals and information and everything. Here are the 10 slides that it already made. You can adjust it here if you want the symptoms before the definition or anything, causes before the symptoms, diagnosis. You can adjust everything. And if you want to add something, you can press go back here. And if you're ready, you can ask it to create it. It's working on it right now. It's actually very fascinating. I just knew about it a week ago, but I don't think I will ever make PowerPoints or presentations the old way again. As you can see, it gives you an overview page, and then we have our slides here, but it doesn't present them as the old way. As you can see, it goes from one slide to the other in an animated way, and it puts all the images for you with all the information. This is just an overview of it. And the motion between the slides. You can always change the design if you want, the palette. You can recreate it if you don't like what you see. After that, you can go to the editor and then switch between the slides to fix whatever you want to fix or to add whatever you want to add. You can even ask the AI here if you don't like what you see. If you you can ask the AI to make it simplify it. You can ask it to make it bullet points. You basically can ask it to do any of the you can ask it to do anything for you. You can change anything. You can adjust the pictures you have here by editing them. You can remove the background or add adjustments. And then you can move between slides in a very even inside one slide, it moves very smoothly, which will make your presentation more interesting and more catchy. So people will get more engaged in your presentation. So this is the how to make a presentation with Prezi AI. After you finish, you can either present it from here. You can click present and then present it through the website, or you can save it and download it as a PowerPoint in your computer if you want to present it by the PowerPoint. Or you can save it as a PDF file too if you want. Okay, this is the first feature that Prezi AI can provide for us. The second feature is uploading a PDF file or a previous PowerPoint file, like I said before. I'm gonna upload a file and show you what it does to it. I'm gonna upload a PDF file. It's just one page. I'm gonna show you the page, the original page, and then I'll show you what Prezi AI does. This is the original page. It's a Millman cardiovascular page. I uploaded it. It got all the information here. And then I'll ask it to generate it. And let's see what it gives us. It summarizes the page. It adds pictures to it. It makes it more interesting and more fun to read it. Okay, it's finished. It made the whole presentation with the information that I gave it. I can change the palette here. I can change the design. I like this better. You can switch between the slides. It's very impressive, to be honest, to try to follow it. The way it moves between the slides is impressive. As I said before, you can edit the slides just like the PowerPoint. And then you can save it. Of course, you can edit the text, the style of everything. You can add media if you want, video, an image you upload from your computer. If you want the AI to create an image for you, let's make him create an image about, let's say, the heart chambers. It's going to give you options to choose from. And then you can add it here. You can use this feature if you don't have images in your computer and you just want something really fast. And you can add it here. This is the second feature. The third feature is the video presentation. No, this one. Okay. The video presentation, this one, you can use the app. They have an app. If you want to import a PowerPoint file and make it as a video presentation. Here's you can add the slides from here. Let's say I want to create a greeting slide. Greetings. You can add the images, videos, whatever you want. And you can have your video next to it. I'm not sure why the video is not. Just a moment, please. Okay, usually you can have my picture here. The video I'm presenting to you will appear here next to this, the content of my slide, but I don't know why it's not working now. I think it's because I have my camera connected to Zoom. I'll try it in a minute. But as you can see, you can add photos from your computer. And then we'll just create the file. This is for a video presentation. You can either record it from here or present in a video call through Zoom meetings or through Microsoft or Google Meet. I'm gonna try to do the Zoom meeting one. I'm not sure why it's not working.
Malaz, on the right lower corner, or there is a small squares, 4 of them.
Right?
To the right. Yeah, what do they do, these, the squares?
The widget.
So it's rigid, okay.
Yes. I want to show you the video because it's really cool, but I don't know why it's not working. You can show your video here on the left and start explaining your presentation next to it in a live presentation or a recorded video that you will share later on. But I don't know why it's not working. So I'm gonna move on to the next point. You can add a PowerPoint file. It's adding it now. Your PowerPoint will appear here. After you can select which slides you want to appear to people, and then import the selected ones only. And they will appear here, either as a full mode or transparent mode where your video will appear in the background, or the floating mode where the slide is on the right and your video is on the left. Just like in the first ones here. So that's it, but I really encourage you guys to try it out and try the video one. I just can't share it now because my video on Zoom is on, I think. And I can't switch it off. Okay, I find it. Just a moment. Turn on it. Let me try again. Okay. Okay, this is what I meant a few moments ago. Can you see my video?
Yes.
Okay, this is how it appears. You can either use the Zoom meetings to show this, or you can record a video. Let's say we're adding our agenda. And here I'm gonna add the PowerPoint. You can also add videos if you want. You can add any kind of files. I'll select some slides to show you how it shows. This is my first slide. You can either choose the floating mode where the slide is on your left and you can start explaining it, or you can put the full mode while going through your slides. It's very impressive. You can't do this with the traditional presentation makers. That's it. Do you have any questions about the video maker?
Thank you so much, Dr. Malaz. This is also excellent presentation. Thank you for
Dr.
sharing this tool. Yeah. I think there is one question. Is it paid or how much the pricing?
Okay, they have plans for payment. They have the free one. It's the basic one. It doesn't have a lot of features, but it can do the presentation. It's just a little bit limited. You can have the individual plan. It's for, I think, $19. And if you're a student or an educator, you can have it, I think, for maybe $7. They have the plans on their website if you check it out. And you can try the free trial. You can even try the premium one with the free trial.
Sounds good.
Thank you.
Thank you. Excellent. Thank you so much. So we can move on to the last part of the presentation or the topics. Any updates? Or we have another item?
Yes, we have Dr. Ruwa.
Oh, sorry. Go ahead. Yes.
Yes, hello everyone. Thank you very much, Dr. Malaz, for your presentation.
Thank you.
Yeah, can everyone see my screen?
Yes, we can see
Yes.
it.
Okay. So I'm presenting today a very short systematic review. Do licensing exams predict clinical outcomes? So licensing and certification exams have traditionally been used to assess and ensure that doctors possess the knowledge and the skills for independent practice. However, there is growing emphasis on workplace-based assessment, which is a senior physician or a senior clinician will supervise a junior one and give feedback about their practice. So a lot of debate has been raised about the validity of these licensure exams, and this systematic review explores this issue. So the purpose of the systematic review is to explore the association between physician performance on national licensing and certification examination and their clinical practice. Okay, so they compare the performance on the exams with the performance of doctors in their clinic and in their daily life practice. Basically assessing their quality of care in comparison to their exam results. So the methodology used for this systematic review, first of all, the review followed PRISMA guidelines for selecting articles from literature. 6 databases were searched up to November 2025. Only original studies were included, studies that focused on the performance of physicians in the exams and the performance in their practice, including the patient outcomes and fitness to practice. The data that has been collected were analyzed using content analysis to identify if there was a pattern or a trend between those two variables. Okay, so The results surprisingly showed that there is actually a correlation between the performance in the exams and the performance in the clinic. The better performance in the exams were actually better performance in their clinics. So 44 studies were included, more than 1 million physicians were assessed, and the better exam performances was consistently associated with, first of all, better preventive care. It was found that there were higher percentages of mammography screening rates, clinical management. There has been improved patient diabetic care and more appropriate drugs prescribing. Third outcome is that patient safety was better for those who performed high in exams. There has been lower morbidity and mortality rates. And finally, professional conduct. There were fewer complaints about those doctors to regulatory bodies, and there has been fewer malpractice payments. So finally, concluding, and the takeaway message is that those national exams are actually a valuable and reliable tools to predict the future of clinical performance. Okay, they cannot be substituted by other, tools. They provide a uniform benchmark for competence. They provide a standardized measure to be met for doctors. And these exams remain critical for ensuring quality of care and standardized assessment in an era of increased physician mobility, just to ensure that everybody is on the same page when it comes to clinical practice. And that was it. Thank you all for being such good listeners. And yeah. Do you have any questions?
Thank you so much, Dr. Ruwa, for this great presentation. It's brief, but it's important topic.
Thank you, Dr. Nader.
Any addition or any questions? We know we have new fellows in this program, so I'd like to welcome all of them. And if there is any one of them has any questions, please go ahead. You can interrupt me. The other point, I think there are some of you working on some projects. So if there is any of you wants to update us, please go ahead.
Yes, hello, Dr. Nadir.
Hello, Dr. Lina, go ahead.
Yes, actually, I have an update about our research in using AI in clinical documentation. And I'm also very pleased to share that our abstract has been accepted to be presented in Inform Conference, which is in North Carolina. And of course, I want to thank you for your guidance. I'm very happy to work with you and of course with our colleague Philo. And I know everyone want to go and to enjoy their weekend, but I'm just prepared like 10 slide presentation to talk about abstract. If you allow me, please.
Yes, please. And congratulations to you and your team. Thanks for sharing.
Thank you. Thank you. Thank you so much. I will be really quick. So. So this is our abstract, which is the scoping review about the patient safety and data privacy and medical legal change in AI-driven clinical documentation. So this is, I'm so sorry, it's a little, we not put well in the slide, but okay. So why this research matter? I want to say that, as you all know, that artificial intelligence is rapidly entering in our clinical environment, and especially in documentation They are used as a documentation tool in large language as large language model, ambient scribe, automated speech recognition system, and there was a lot of evidence about their efficiency and how they are help doctor to decrease the burden of administration work. But so our research question was: are they really accurate? Is this safe? Or if there's any mistake, who is legally responsible for that? So this is our objective we want to map out any evidence about AI-based clinical documentation tool across healthcare setting. We want to evaluate the implication for this documentation accuracy and patient safety, to assess the data privacy and concern, and also to examine if there's any medical legal accountability. Okay, so how we did it? Of course, we work our scoping review. We follow the prisma of scoping review guideline. First of all, we search on 6 databases: PubMed, Embase, and IEE, and ClinAll, and Scholar. Our research time range was 6 years, from 2020 to 2026. After full screening, we ended with 27 study with which has diverse design from randomized clinical trial and observation or qualitative study. So, about the finding, the most striking finding was about the error. We found out that AI had a special type of error that's most common, which is omission error. So the problem that most of the time, AI will not write the wrong thing, but it left thing out. Let me give you an example for that. Maybe sometimes if I'm documenting about my patient who presented with acute abdominal pain, and he had constipation, nausea and vomiting, while I'm documenting there's part of the history talking about previous surgery, AI sometimes can take out this information, which is very important in making differential diagnosis. So this was a real issue regarding the safety risk. And also there was a lot of hallucination error, which is differ according to the type of AI use. Sometimes it's maybe it's mostly common in the general purpose, as like there's some clinics using like ChatGPT or some general AI app that had the highest hallucination rate. So the other finding, which was data privacy, which there's of course sometimes there issue of patients sometimes share some vulnerable information about themselves, and there I can say that some issues of third party data sharing, and also the limited transparency. So where did data go? Is it shared with other companies? Is it just in the there's some limited data about the transparency. And also there's weak regulatory oversight. There's no, or I can say that current framework have not kept pace with the speed adoption of the clinical. So there's no certain framework that can show what is the efficacy, if privacy, or the effect of using this tool on clinical documentation on data privacy. And also there are certain type of bias that have shown they have a direct implication on the care quality and equity. There's like algorithmic bias, linguistic bias that really share disadvantage in people or in clinicians who are not native English speaker. There's also demographic bias, perceptive bias, reporting bias, and selection bias, and automation bias. So also there's some medical legal accountability, and I can share that this is the most underdeveloped area and the most area that need a lot of research. because we couldn't find a concrete answer. So if anyone is interested in this part, I think this is a great research gap, because there's a lot of there's a lot of question without answer. Like if there's AI generated error who that lead to patient harm, who is the responsible? Is it the physician, or is the hospital, or the company who built the AI system? So what we conclude from our research, that the most common risk is omission risk, up to 83.8 of error, and also their real privacy gap in using AI tool in clinical documentation, and also its lack the legal clarity, which is urgently in need to follow up with the use of this AI in clinical documentation. So our recommendation, of course, is to use human in the loop validation must remain non-negotiable. We have to have a pause for at least like 5, I don't know the time, maybe minute, so the physician can revise the tool generated by this, so he can revise the nodes that generated by this tool. Also, enforceable data governance framework must be developed and implemented. And also, as I said, I encourage future researcher to study more and evaluate the error rate, especially the omission, and to try to cover the gaps that found it. And yeah, that's it. Thank you so much. And as I said, that AI had the real potential to transform clinical documentation, but must be guided by evidence and clear rule and grounded in patient safety. Thank you so much.
Thank you so much, Dr. Lina, for sharing this important topic and wonderful abstract idea and research project. So thank you so much and congratulations. My 2 points. Number one, I think it's good questions that you raised here. So maybe I suggest that in addition to present this as a poster, I think you can elaborate and work this as a manuscript and submit it to some of the journals. So if you have enough people in your team, or if you want some of the other fellows who are interested, maybe they can join the team and write it as a paper. My other point is it's just an idea, and I'm sharing the background. So when I was working with my other colleague seeing patients at the university, we were required to do auditing. So I will look at my colleague's note and see if they billed to the insurance the right level and they documented equal amount or correct notes, and they do the same for me. And this will help with quality improvement. So if they saw something negative in my notes, let's say I am omitting something, or I overbill, or I don't document the right way to meet the criteria for billing, then they will raise the points that I can improve in this. I will take it easy so that I can improve next time, and I will do the same for them. This is just the background, but for you, maybe you can use it as a way to suggest the AI use to improve itself. In a sense, nowadays you have the AI help people write and submit, let's say, papers. The journal, they have another tool, AI, that detect whatever written by an AI. So in your topic, you can say, we see that AI is used to generate medical notes, and we don't know how to improve that beside the time the person in the room or in the loop. But we can advise or recommend generating or creating new AI that oversee or audit what we get out of these notes. Let's say I dictate a note about a patient. The AI will transport or transfer or to transcribe that into a note. And one of the things, as you mentioned, maybe they will omit the surgical history. that AI, that note generated by the AI, can be reviewed by another AI tool, comparing the output, the text note, with the dictation, the voice file that I did, and see if there is any omission and raise points against the AI generated. So next time, the AI will learn from itself and will improve in that sense, if that makes sense. So like detection of omission in AI generated clinical notes, for example.
Yes, actually, this is a very great idea. I think will create a new direction to testing AI by using AI. Yes, I think this is. I would try to implement this point or try to discuss it as something we can use or something we can recommend, right? To try to solve the omission error
Sounds good.
problem.
Yeah.
Yeah. Exactly. And of course, I would try to work with that. I'm open for anyone who want to participate to transmit this. I have all the data. Just anyone who want to help in writing process. Yes, if there's any fellow available, we're open to that.
So the idea is to work with you for other fellows to join you as a new team to
Yes.
work to write a manuscript, to write an article that can be submitted to the conference. Thank you.
Yes.
To the journal, I mean.
Hello,
Any
Dr.
other
Nadir,
questions
and hi
or any other
everyone.
comments? Go ahead.
Hi everyone. Dr. Malaz Salah. Thank you so much, Dr. Nadir, for this opportunity, and thank you everyone. Thank you, Dr. Malaz. I would like just to give a quick update about our abstract titled "A Mobile Application-Based Innovation to Educate Staff on Fire Drill Preparedness in Post-Acute and Long-Term Care Settings." Focuses on improving emergency preparedness and enhancing patient safety through a mobile-based education approach. I submitted this abstract to Healthcare Dubai Conference, 2026 International Conference, organized by Scientific, brings together healthcare professionals and researchers from different fields, from different countries. The conference included several tracks such as patient safety, research, digital health, and medical education. And when I submitted the application form and explained clearly how our project fits within the patient safety and research track, especially in terms of improving safety and using a structured approach that can be applied in real settings. And Alhamdulillah, our abstract has been accepted for presentation at the conference. And I will present it, inshallah, next Monday. I received actually, I was literally stressed and I had a short time even so. I found the conference, you can say, on 14th of April, and it was the same day of deadline for presenting the abstract, for submitting the abstract. And I submitted it, but alhamdulillah, everything going good. And inshallah, I'll present it on Monday. They was shared with me the letter of acceptance, and was shared with me even so the schedule. It will be on 20, sorry. It will be on 20. I'll present it orally, inshallah.
Excellent. That's congratulations. This is excellent news. Wonderful.
Thank you so much, Dr. Nadir. Thank you for everything. Thank you for your help, for your support all
You're
the
welcome.
time.
Yeah, thank you. Thank you, you and your team. Congratulations. You did great work. So if it's recorded, can you share the recording when you are done presenting? That would be great as well. Thank you. Anyone else?
Hello, Dr. Nader. This is Nabiha here. I am new to the
Hello.
program, and first of all, thank you so much for adding me to the program. It is my first day and first session, so I really enjoyed the session throughout, and I found it very informative and a very good opportunity for me to learn and grow. And I look forward to it, and I hope I am able to contribute to it. Thank you so much.
You're welcome. Thank you, and welcome to the program.
Thank you so much for giving me the opportunity.
Thanks. Any other questions or updates or new ideas, questions about the projects or about the program? If not, I'd like to thank you all for joining this meeting, and I'd like to thank all the presenters from today, the organizer and the team leader. Thank you all for great job that you did, and I wish you all the best. If you have questions, any comments or ideas, research, please contact me. You can send an email, a text, WhatsApp, or call me, text me, and we will help you as much as we can. And I'd like to thank those who will look at the and watch the recording in the future. Have a wonderful day wherever you are, or have a wonderful night. See you next week. Assalamu alaikum. Bi amantillah.
Thank you, Dr. Nader.
Thank you, Doctor.